Greetings, and thank you for attending this virtual presentation of Isomid, a new diuretic available for treatment of heart failure in dogs with myxomatous mitral valve disease. I am pleased to present this information on behalf of SIVA and to provide my perspective on the efficacy and safety of Isomid for this indication. The availability of Isomid offers, for the first time, a choice of loop diuretic agents when treating congestive heart failure. I hope you will find the following information helpful and intriguing. For those attending the webinar on November 6, 2020, I will be available live for questions following the conclusion of this presentation. These are my disclosures. Over the next 45 minutes, I will offer a brief review of Isomid's relevant pharmacokinetic and dynamic properties, and compare the potency of Isomid with furosemide. We will then spend the remainder of our time examining the results of the CARPODIEM clinical trial and how these results led to approval of Isomid for treatment of first-time heart failure in dogs with degenerative valve disease. I will close with some thoughts about how one might incorporate Isomid into clinical practice. Isomid is an oral formulation of the loop diuretic torsemide, which is also spelled with an A and called toracimide. Torsemide acts in the ascending loop of Henle, where, similar to furosemide, it blocks the sodium-potassium chloride cotransporter. The decreased resorption of sodium from the nephron lumen promotes natriuresis and diuresis. As you know, loop diuretics, as a class of drugs, are considered potent diuretics due to the relatively large amount of sodium that is normally absorbed in the loop of Henle, and the limited ability of downstream nephron segments to compensate for this blockade. There are important similarities and differences between torsemide and furosemide with respect to their pharmacokinetic characteristics. This table summarizes some of the main pharmacokinetic properties of the two drugs. Let's start by looking at three important differences between torsemide and furosemide that involve the drug's bioavailability after oral dosing, its half-life, and its potency. Specifically, the oral bioavailability of torsemide is greater and more consistent as compared with furosemide, and is less affected by its relationship to administration with or without food as compared to furosemide. The plasma half-life of torsemide is approximately twice as long as furosemide. This, in relation to the duration of effect, enables torsemide to be administered using less frequent dosing, that is, once a day as opposed to twice a day. With regards to potency of diuretic effect, when dosing on a milligram per kilogram basis, torsemide is 10 to 20 times more potent than furosemide. Both drugs are extensively bound to plasma proteins and therefore require active secretion into the nephron tubule. That is, neither drug is filtered into the tubular in the glomerulus, but rather requires the cells of the proximal convoluted tubule to transport the diuretic from the bloodstream across the cells that line the nephron and into the nephron's lumen. The main excretion pathway for both drugs is through the urine, although a small amount is metabolized in the liver. Both drugs begin to exert a diuretic effect rapidly after oral ingestion. This slide shows the effect of these properties on the clinical usage of Isomid. This is a graph showing equivalent volumes of urine that are produced over a 24-hour period when dogs are given either diuretic. You will note that once daily Isomid causes the same amount of urine production as twice daily furosemide. The top two panels show urine production after the first dose, and the lower panels show urine production after repeated dosing. The once daily dosing of Isomid is one of its unique features, and how this might affect owner compliance in giving medications will be discussed later in this presentation. Secondly, Isomid is more potent than furosemide. Along the x-axis are increasing doses of Isomid and furosemide. If we convert the data on this graph into tabular form, we can examine the relative doses among the drugs. The first row of values is the daily furosemide dose, followed by the corresponding 24-hour urine volume in the row directly underneath. The third and fourth rows show the daily isomide dose and the daily urine volume. This table allows us to compare the dose of torsemide versus the dose of furosemide in the setting of equivalent amounts of diuresis. Examination of the data indicates that on a milligram per kilogram basis, torsemide is between 10 to 20 times more potent than furosemide with respect to producing equivalent amounts of diuresis. At relatively low daily furosemide doses, between 1 to approximately 3 milligrams per kilogram a day, an equivalent amount of diuresis is produced when isomid is given at a tenth of the existing furosemide dose. At higher daily furosemide doses, doses at or above 5 milligrams per kilogram a day, an equivalent amount of diuresis is produced when isomid is given at a 16th to 20th of the existing furosemide dose. This suggests that there is no one single conversion factor when converting a furosemide dose into a torsemide dose. The nonlinear potency of torsemide results in some important dosing considerations, as we will discuss in a few minutes. With that background in mind, let's next examine the results of the pivotal clinical trial that led to isomide's approval in the EU. This study was referred to as the CARPODIEM study, or the canine relief of pulmonary edema by diuretic easy management. The CARPODIEM study was a prospective, multi-center study performed in 6 different countries or regions in the EU. The intent of the study was to demonstrate the clinical efficacy and safety of isomide in dogs experiencing their first episode of congestive heart failure due to mitral valve disease. That is, the study specifically recruited dogs that had for the first time progressed from being asymptomatic to stage C, or with congestive heart failure, and as such required diuretic therapy for the first time. These dogs had what was referred to as first onset congestive heart failure or pulmonary edema. The study randomly assigned dogs to receive either isomid or furosemide as their diuretic therapy. In order to decrease the chances of bias, both the dog owner and the attending veterinarian were blinded as to the drug assignment. In cases of emergency, this blinding could be removed and the identity of the diuretic known by the veterinarian. The results of this trial were published in the Journal of Veterinary Internal Medicine in the summer of 2020. The main efficacy endpoints were to show that the clinical effect of isomide over a 14 and 84-day period were non-inferior to furosemide. That is, treatment with isomide was no worse than treatment with furosemide. Primary proof of efficacy required reduction of radiographic pulmonary edema and any existing cough, and no worsening of dyspnea or exercise intolerance as compared to baseline. This primary efficacy endpoint was examined on day 14 following the start of the diuretics. A second efficacy endpoint was defined as reduction of existing cough and either reduction or no worsening of radiographic interstitial pattern and no worsening of dyspnea or exercise intolerance. This secondary endpoint was evaluated on both day 14 and day 84. At first glance, these criteria might seem a bit confusing, but they are very important, so I want to spend a minute diving into them a bit more. As you know, common clinical signs of heart failure due to mitral valve disease involve increased respiratory effort, development of a cough, or exercise intolerance, but these signs are variably present in any individual dog. Moreover, the severity of any of these clinical signs can also vary. For instance, the degree of dyspnea might be severe and obvious to both owner and veterinarian, while in other cases, only a mild increase in respiratory effort might be noted. In such a case, the owner might have been alerted to change in their dog's clinical status because of a new cough or reluctance to do activity. Thus, any efficacy endpoint has to be flexible enough to capture the wide range of signs and responses to medications that occurs. In conjunction with input by the EU's regulatory agency, the developed criteria represented the minimal expected or acceptable clinical response. That is, dogs could, and indeed most did, demonstrate improvement in most or all of these signs following diuretics. But at the very least, dogs receiving either diuretic must have had improvement in cough and no worsening of dyspnea or exercise intolerance in order to be considered effectively treated. These criteria allowed for dogs with relatively mild clinical signs to be evaluated using a system that was sensitive to either improvement or no substantial worsening of mild signs. Importantly, the primary efficacy criteria upon which the study hinged required a reduction in radiographic pulmonary edema. This requirement helped ensure that any improvement in clinical signs was linked to resolution of radiographic edema. Finally, you will note that the secondary efficacy criteria maximized sensitivity in that it was acceptable for dogs with a mild interstitial pulmonary pattern, or what was assigned as score 1, to not completely resolve as long as the other clinical criteria were met. Again, this endpoint allowed for the fact that older dogs often have a mild interstitial pattern as a result of their age or concurrent respiratory disease, and some amount of interstitial pattern is always present, even after resolution of congestive heart failure. The use of these primary and secondary criteria was deemed as the most appropriate means to compare responses to the two diuretic drugs, and met the requirements of the EU regulatory agency. This slide shows the recruitment criteria. Dogs were eligible if their body weight was between 2.5 and 60 kilograms. They had to have a murmur consistent with mitral valve disease. Their left atrium to aortic root diameter ratio on echocardiogram had to be equal to or greater than 1.5. Their vertebral heart size on radiographs had to be greater than 10.5, and pulmonary edema had to be present. Clinical signs of heart failure included dyspnea, exercise intolerance, or cough. And dogs had to have no known renal disease, defined as BUN greater than 47 milligrams per deciliter, or a creatinine greater than 1.6 milligrams per deciliter. With respect to concurrent or previous therapy, dogs must have been either naive to any cardiac treatment or treated with an ACE inhibitor, pimobendan, and/or spironolactone at a stable dosage for at least 4 weeks prior to study entry. Dogs were not allowed to have received IV diuretics or have a need for hospitalization. No treatment with an oral diuretic was permitted, except for oral furosemide at a dose not greater than or equal to 4 milligrams per kilogram a day for a maximum of 2 days prior to study entry. Digoxin, beta blockers, calcium channel blockers, and other vasodilators were prohibited. During the study, dogs were withdrawn from participating if their condition was such that they needed changes to their basic background therapy within the first 14 days, or they required diuretic doses above a pre-specified limit, meaning that control of congestion was no longer possible with what would be considered high doses of oral diuretics. We already alluded to the fact that dogs with first onset congestive heart failure due to mitral valve disease demonstrate variable degrees of clinical signs, ranging from mild to severe. Thus, the study allowed the veterinarian the flexibility to prescribe either a, quote, standard dose of diuretics or to temporarily administer a higher initial dose and then titrate back down to the standard dose as clinical signs improved. The different doses of isomid and furosemide are displayed on this slide. Depending on the severity of signs, dogs either received isomide once daily at 0.13 milligrams per kilogram a day with a permittable range of 0.13 to 0.25 milligrams per kilogram a day, or furosemide twice daily at 1.3 milligrams per kilogram a day with a permittable range from 1.3 to 2.5 milligrams per kilogram a day. You will note that at dose level 1, the standard dose, the dose of isomid is 1/10 the dose of furosemide, which reflects the previous findings that at relatively low furosemide doses, torsemide at 1/10 the dose of furosemide produced equivalent amounts of urine production. In dogs with more severe clinical signs, diuretic dosing of Isomid was twice the lower dose, 0.26 milligrams per kilogram a day, with a maximum permissible dose of 0.5 milligrams per kilogram a day. Dosing of furosemide was 3.5 milligrams per kilogram a day, with a maximum permissible dose of 7.5 milligrams per kilogram a day. These higher doses could be given for up to 5 days, after which the dose was decreased to be within the lower dose range we previously mentioned. If dogs required treatment that was more sustained than this, or at doses higher than what is described, dogs were withdrawn from the study. At the higher dose level, or dose level 2, you will note that the equivalent amount of Isomid is 1 to 13 or 1 to 14 the dose of furosemide, as opposed to 1 to 10, which reflects the nonlinear nature of torsamide's dose effect response as compared with furosemide. After enrolling in the study and being assigned to either Isomid or furosemide, a recheck was performed 4 days later, and physical examination, serum chemistry, and thoracic radiographs were performed. This recheck helped ensure that the dogs were clinically improving and that no adverse effects associated with initiation of diuretic therapy was noted. 14 days after starting diuretics, dogs returned to the hospital to determine whether the treatment was effective according to the criteria we previously described. As a reminder, during the first 14 days, no changes to concomitant cardiac medications nor introduction of new cardiac medications was permitted. If the dog's condition necessitated either a change or new medication, the dog was withdrawn from the study. From day 14 onward, the goal was to determine whether or not the effective Isomid continued to be non-inferior to furosemide for up to 84 days, or approximately 3 months after the initial onset of congestive heart failure. During this time, one is interested in whether dogs will remain free of reoccurrence of congestive heart failure and avoid any adverse side effects. The 3-month follow-up period is important in that it represents about 1/3 of the median time that dogs with first onset heart failure are typically expected to survive. Previous studies have shown that the median survival time in dogs with heart failure due to mitral valve disease, that is, the time at which 50% of dogs will have died, is 9 months. Thus, the clinical response over the first 3 months of treatment represents a substantial proportion of time believed to be left for this population of dogs. In addition to evaluation of efficacy, the safety and tolerability of Isomide as compared to furosemide was evaluated over the initial 14 days and then subsequent 84-day period, and this is the subject of the next slide. An important goal of the study was to evaluate the safety of Isomid, and over the course of the study, dogs were monitored for any adverse events, or what the EU regulatory agency terms AEs. Under their definition, an AE is any unfavorable observation that occurs after study enrollment, regardless of whether or not the event is considered related to the study drug. For instance, a ruptured cruciate or flea bite dermatitis are recorded as AEs. Any unfavorable observation also includes any blood test whose value is outside the normal reference range, regardless of the clinical importance of such findings. Thus, a BUN or ALT result 1 unit higher than the reference range is recorded as an AE. Investigators are allowed to hypothesize which AEs might reasonably be due to the study drug and which are probably unrelated, but all AEs must be included in the overall number that occurred during the study. Finally, life-threatening or debilitating AEs are classified as serious AEs or SAEs, and their potential relationship to the study drug is also considered. The number and nature of AEs and SAEs helps determine the comparative safety and tolerance of the 2 study diuretics. There is one final endpoint to consider before we move on to the study results. As we previously mentioned, median survival time of dogs with congestive heart failure due to mitral valve disease is approximately 9 months. an important consideration involving different medications is their effect on this time. In the CARPODIEM study, the time it took dogs to experience death or euthanasia due to cardiac causes, such as persistent or severe congestive heart failure or sudden death, or withdrawal from the study due to either need to introduce new medications other than the study diuretics in the initial 14-day treatment period, or need for doses above the allowable ranges for either torsemide or furosemide was examined. The rationale to accept either of these outcomes lies in the assumption that cases which fail to respond to conventional therapy typically have a grave prognosis. When we review results, it is important to remember that the effect of diuretic drug on time to cardiac death or treatment failure was not the main basis for this study, and these analyses were approved and conducted as a means to explore how the different characteristics of the two diuretic drugs might affect these important clinical variables. Finally, the study also asked owners to rate their dog's quality of life using a previously developed questionnaire specifically designed for this purpose, called FETCH. And now on to the results. The study took place between 2013 and 2015 and enrolled 321 dogs with first onset heart failure due to mitral valve disease from 6 different countries or regions within the EU. 2 dogs were found to have violated the enrollment criteria and were excluded, leaving 319 dogs that received at least 1 dose of the study diuretic. This population of 319 dogs, called the safety population, was used to assess the safety and tolerance of the study diuretics. Shortly after randomization to study drugs, an additional 4 dogs were found to have not fully met the inclusion criteria and were subsequently excluded, leaving 315 dogs. This population of 315 dogs, called the Full Analysis Set, or FAS, was used to assess the efficacy of the study diuretic. Examination of the study population shows a typical cohort of older small breed dogs. The average age was approximately 11 years, with slightly more males, 179, than females, 136. Average weight was between 8 and 9 kilograms. There were no significant differences with respect to severity of congestive heart failure, concurrent medications, quality of life, echocardiographic measurements, or blood values between dogs receiving isamide as compared with dogs receiving furosemide. This slide shows the results of the primary efficacy endpoint. Treatment success, including improvement in radiographic edema and cough, and at a minimum, no worsening of dyspnea or activity intolerance, as evaluated 14 days after starting diuretic treatment. Treatment success was achieved in 74.4% of dogs receiving isamide and 73.5% of dogs receiving furosemide. Statistical analysis showed that this result met the pre-established criteria for non-inferiority, meaning that isamide was non-inferior, no worse, than furosemide in resolving clinical signs associated with first-onset heart failure in dogs with mitral valve disease. Specifically, the study's pre-specified definition of non-inferiority was based on a requirement that the absolute difference in treatment success between torsemide and furosemide would not exceed 15%. This meant that the value of the lower 95% confidence interval of the risk ratio estimate would not be less than 0.77. And in the study's case, the lower value was 0.89, which successfully met the definition. This result satisfied the main objective of the study. As you might remember, veterinarians had the option of selecting 2 doses of either diuretic, and in dogs initially receiving the lower dose to change to the higher dose depending on the severity or persistence of congestive signs. In dogs initially receiving the lower dose of either torsemide or furosemide, the number of times that the veterinarian felt the need to increase the dose due to incomplete resolution of signs was higher in dogs receiving furosemide, 7.4% of times, as compared to dogs receiving torsemide, 1.3% of times. You will recall that a secondary measure of treatment efficacy was also evaluated, at day 14 and again at day 84. At both time points, Isomid fulfilled the pre-specified definition of non-inferiority. Specifically, the percentage of dogs meeting the definition of success at day 14 was 82.1% in dogs receiving Isomid, and 80.1% in dogs receiving furosemide. At day 84, success was achieved in 60.8% of dogs receiving Isomid and 58.9% of dogs receiving furosemide. Fulfillment of both primary and secondary criteria at day 14 and secondary criteria 3 months after starting diuretics provides a high degree of confidence in the results. Thus, it was concluded that Isomid can be used to resolve clinical signs associated with first onset of heart failure in dogs with mitral valve disease, with results that are no worse than results achieved with furosemide. This graph shows the radiographic pulmonary edema scores at baseline and days 4, 14, 42, and 84 of the study. The higher scores and more severe degrees of edema are shown as the darker shades of green and orange, and you will note that over the course of the study, scores improved, as evidenced by greater proportion of dogs in the lighter shades of green and yellow. These changes are consistent with resolution of edema once diuretic therapy starts. The change in these scores was similar between study drugs. This graph shows the clinical class of heart failure using the ISA-CHC system, wherein stage 2 and 3A include dogs with clinical signs, here shown as the darker shades of green and yellow, and class 1C, which are dogs with resolve signs, shown in the lighter shades. Consistent with the improvement in clinical signs and radiographic signs of edema, the clinical class of heart failure improved from 2 and 3A at baseline to class 1C and 2 over the study duration. This graph shows the fetch scores at baseline and at days 14, 42, and 84. Remember that the lower the fetch score, the higher the owner's perceived quality of life of their dog. There were similar improvements in quality of life between study drugs over the duration of the study. This graph shows the NT-proBNP concentrations. You recall that NT-proBNP is an indicator of volume overload and myocardial stretch. The median NT-proBNP at baseline was elevated between 1,300 and 1,600 picomoles per liter and was lowered after treatment in both groups. Consistent with what we know about BNP in the dog, there was a wide range of individual response among subjects. But as will be shown in a few minutes, higher baseline NT-proBNP was associated with a shorter time to cardiac death or treatment failure. You will also recall that the study explored the time between initiation of study diuretic to either death or euthanasia due to cardiac causes or to treatment failure. Remember that treatment failure primarily involved the need for relatively high doses of diuretics or the need to introduce additional diuretics or medications. The Kaplan-Meier graph shown here displays the rate at which dogs receiving either study drug experience death or treatment failure. On the upper left of the graph at time 0, the start of the study, all dogs are alive and on allowable medications, hence the survival probability is 1. As time goes on, some dogs either die or experience treatment failure, and the proportion of dogs remaining in the study begins to decrease. As this happens, the curves slowly move down the y-axis. Analysis of these curves demonstrated that dogs receiving furosemide experience either death or treatment failure at an earlier time than dogs receiving Isomid, and that this difference was statistically significant. If you look at the table which shows the number of dogs either dying or experiencing treatment failure amongst treatments, you will see that the main difference lies within the group of dogs that required either high diuretic doses or additional medications. Thus, one inference from these data is that veterinarians needed to increase doses of diuretics in dogs receiving furosemide sooner than in dogs receiving Isomid. This data agrees with the previous finding that more veterinarians increased the initial dose of diuretics in the first 14 days of treatment in dogs receiving furosemide, and that the need to increase furosemide dose persisted such that achievement of the highest allowable dose occurred sooner. This next slide helps quantify the findings of the Kaplan-Meier curve with respect to a dog's risk of experiencing death or treatment failure. This slide shows some of the 26 different variables that were examined. I attempted to show ones that might be of most interest. Results for all 26 variables are presented in the scientific manuscript. These data are the results of what is called a frailty model analysis, which is an extension of Cox proportional hazards analysis, but has a better accounting of the heterogeneous nature of the study population and for any unrecognized variables that might influence results. Previous reporting of results from the CARPODIEM study, such as at the 2019 ACVM Forum, presented results from the Cox proportional hazard analysis as was approved by the EU regulatory agency. When the results of the study were submitted for publication to the Journal of Veterinary Internal Medicine, manuscript reviewers asked that results from a frailty model be shown in place of Cox proportional hazard. The results from either method reach the same conclusion, and I'll be showing you the results as published in the scientific manuscript. The first column lists the variables shown to be associated with the time it took for dogs to experience cardiac-related death or treatment failure. The remaining columns, including what is called the hazard ratio, HR, quantify the relative risk of death or treatment failure for each variable. For instance, in looking at heart rate, dogs with heart rate greater than 150 beats per minute were 2.37 times more likely to experience death or treatment failure than dogs with heart rate less than or equal to 150 beats per minute, and this result was statistically significant. In reviewing these results, it is not particularly surprising that large hearts, represented by radiographic vertebral heart size and the left atrial to aortic root diameter ratio, more clinical signs, reflected by the ISA-CHC class of heart failure, were associated with increased risk. Other variables, including duration of heart disease, age, and renal function, were not associated with increased risk. With regard to isamide versus furosemide, isamide was associated with significantly lower risk of death or treatment failure. This finding was further explored in a multivariable analysis, which is the subject of the next slide. Following examination of the univariate analysis, variables with p-values less than 0.2 were entered into a backwards multivariable analysis. The resultant output identifies variables independently associated with time to cardiac death or treatment failure. These included the diuretic treatment, severity of dyspnea, NT-proBNP concentration, heart rate, and the echocardiographic size of the left atrium. The cutoff values used to separate the study population on the basis of each variable is shown in the second column. The remaining columns include the hazard ratio, HR, the confidence interval, and the p-value. Here, the hazard ratios are a bit different than the univariable ones due to the fact that they represent the association after adjustment for all the other variables in the model. For instance, in looking at heart rate, after adjusting for the 4 other variables, dogs with heart rate greater than 150 beats per minute were 1.7 times more likely to experience death or treatment failure than dogs with heart rate below this value, and this result was statistically significant. One can see that dogs with NT-proBNP greater than 900 were 3.85 times more likely to experience cardiac death or treatment failure versus those with lower values. Let's look specifically at how the study diuretic was associated with risk. You will note that the hazard ratio is less than 1. This indicates that dogs receiving isamide were at lower risk to experience cardiac death or treatment failure, as compared to dogs receiving furosemide. The 0.36 value for the hazard ratio is interpreted as dogs receiving isamide had 0.36 times the risk as dogs receiving furosemide. Put in other terms, after adjusting for the other variables, there was a 64% reduction in risk of cardiac death or treatment failure in dogs receiving isomide versus dogs receiving furosemide. The 95% confidence interval of this reduction ranges from 35% to 81%. One should keep in mind that this result primarily was driven by the reduction of treatment failure, as we saw on a previous slide. Why go through all this trouble to further analyze the Kaplan-Meier curve or univariable analysis, which already indicated that dogs on isomide took longer to die of cardiac causes or to experience treatment failure? The reason for this analysis is that it can look at more than one variable at the same time. Each variable in the first column is independently associated with the time it took, but the multivariable analysis is a better reflection of the real-world circumstance in which the dogs receiving diuretics have variable degrees of dyspnea, different NT-proBNP values, different heart rates, and left atrial sizes. These sorts of multivariable analyses are more quote-unquote holistic in their approach, taking into account more of the clinical picture than just focusing on a single variable. In the next several slides, I want to show some additional results having to do with safety, tolerance, and owner compliance. Firstly, I'd like to show some results specific to safety and tolerance of isomid. As you remember that by definition, any unfavorable finding during the study is an adverse event. As a result, the number of AEs over the course of the study can be high. And during the CARPODIEM study, 60.5% of the safety population, or 193 dogs, experienced at least one AE. Significantly more dogs receiving isomide experienced an AE as compared with dogs receiving furosemide, 109 dogs, or 67.7%, versus 84 dogs, or 53.2%. The majority of AEs, 84.3%, were classified as non-serious, the large majority of which were self-limiting and required no treatment. These included such things as a BUN value outside the normal range, but unaccompanied by any clinical signs. In the second table, you can see that the number of dogs experiencing a non-serious AE related to kidney or the urinary tract system was higher in dogs receiving isomide versus those receiving furosemide, 41.6% to 19.0%. AEs related to non-kidney systems, such as the GI or respiratory tract, were similar among groups. This finding likely speaks to the relative potency of torsemide as compared to furosemide. Remember that torsemide is between 10 to 14 times more potent than furosemide. Thus, the increased incidence of non-serious renal AEs might suggest a greater amount of diuresis and pre-renal azotemia. By and large, the investigators did not believe that these non-serious AEs indicated acute kidney injury or kidney failure, as they were self-limiting and did not trigger any specific treatments, such as cessation of diuretics. The next two slides examine the renal variables throughout the course of the study more closely. In the graph on the left, BUN is on the y-axis with a value of 50 millimoles per liter as the uppermost value. The upper reference range of approximately 10 millimoles per liter is shown by the dotted line. Along the x-axis are the various times at which the BUN was measured from day 0 to day 84. Dogs receiving isomid are in green, and dogs on furosemide are in brown. On the right is a similar graph, but with serum creatinine on the y-axis, the uppermost value being 700 micromoles per liter, and the upper reference range of approximately 125 micromoles per liter, shown by the dotted line. These graphs give you a sense of the typical values observed during the study. Again, consistent with the potency of torsemide, you can see that the BUN values in the isomide dogs tended to be higher than in the furosemide dogs. However, the large majority of BUN values did not exceed 15 to 20 millimoles per liter. A similar effect is noted in the creatinine results, with the large majority of values remaining below the reference limit in both groups. This slide shows the urine-specific gravity at days 0, 15, and 84. You can see that the urine is more dilute and the USG is lower in the dogs receiving isomid at both day 14 and day 84. As we have stated, this reflects the relative potency of diuretic action of torsemide. This slide shows the number of serious adverse events, or SAEs, within each group. There were more SAEs in dogs receiving Isomid, 28 to 16, but this difference was not significant. In the second row, we can see that there was no difference in the number of dogs either dying or being euthanized due to SAEs between the groups. As death or euthanasia is the most serious of adverse events, let's look at these more closely. With regard to the 12 dogs receiving Isomid that either died or were euthanized, 10 of 12 were due to known or presumed cardiac causes, involving such clinical signs as sudden death or acute respiratory distress. The remaining 2 dogs receiving Isomid died from non-cardiac causes, including 1 for sudden onset of ataxia and 1 for pyometra. With regard to the 11 dogs receiving furosemide that either died or were euthanized, all 11 were done so for known or presumed cardiac causes. This slide shows data regarding owner compliance in dosing either Isomide SID or furosemide BID during the initial 14-day treatment period. This was done by counting the number of tablets remaining at the 14-day recheck. While compliance related to either diuretic is high, compliance was significantly higher in the SID Isomid group as compared to the BID furosemide group. Isomid is formulated as a flavored tablet, and 80% of dogs in the Isomid group voluntarily ate the tablet either alone or with food without the owner having to force the medication into the dog's mouth. A little more than a quarter of dogs ate the Isomide tablet without any food, as compared to only 8% of dogs receiving furosemide. There are many other aspects of the CARPODIEM study that you might be interested in, and we refer you to the scientific report published in July of 2020 in the Journal of Veterinary Internal Medicine. Online access to the journal is free. In conclusion, I'd like to highlight the following points. The CARPODIEM study sought to evaluate the efficacy and safety of Isomid in dogs with first-onset heart failure, specifically in the form of pulmonary edema due to degenerative mitral valve disease. It fulfilled its primary and secondary objectives in showing that treatment with Isomid was non-inferior, no worse, than furosemide after 14 and 84 days of therapy. Dogs receiving Isomid experienced a 64% reduction in the risk of death or euthanasia due to cardiac causes, or the need for high doses of diuretics or additional cardiac medications. This finding was mainly driven by the latter outcome. Dogs receiving Isomid were less likely to require dosage increases during the first 14 days of treatment as compared to furosemide. Non-serious adverse events, such as subclinical increases in BUN and creatinine, were common in both groups, but more so in dogs receiving Isomid. The number of dogs experiencing serious adverse events was numerically higher in the Isomid group, but not statistically different among groups. A similar number of dogs in either group died from either cardiac or non-cardiac causes. No dog in either group died of kidney complications. Overall owner compliance during the first 14 days of diuretic therapy was high, but significantly greater in dogs receiving SID Isomid. This slide summarizes the current recommendations for the use of Isomid in treating first-onset heart failure in dogs with mitral valve disease. Depending on the severity of signs, 2 different dose levels are available. If the higher dose is used, attempts to titrate back down into the lower dose range is recommended. The high dose should not be used for more than 5 consecutive days. As with all diuretics, monitoring of hydration status, water consumption, urination, as well as blood testing of BUN, creatinine, and electrolytes is recommended. These dosing recommendations are included in the package insert. Torsemide is provided as 1, 2, and 4 mg flavored tablets suitable for SID dosing. I hope this presentation was useful and informative. For those of you attending the webinar on November 6, 2020, I will be available for questions. Thank you to all the dog owners and veterinarians that participated in this study.